This is the ease operation. My first few was 2 hours. Okay. I hope that if you do something a lot, you'd be better at it. So it takes me about 45 to 60 minutes under endoscopic guidance. Now, it's either sedation or general anesthesia, depending on the setting. You could actually do this procedure under local anesthesia, but something in the nose for, with the scope is not the most comfortable. Okay.
Of course.
So it takes me 45 to 60 minutes. Now, you could see from those patients at the end of the operation, they are expanded.
Mm-hmm.
Okay. The sutures are separated. This is a misconception. The expansion of the nasomaxillary complex is what I call force transfer. I am exerting force on the palatal bone so that the force will transfer superiorly to affect the facial sutures. This makes sense? That's that's the objective. So I do not want, there's no guessing game, okay? I do not want to waste the force on trying to split the suture.
Mm-hmm.
Okay.
What tool do you use inside of the nose that's able to so you cut down? Is that right?
I am not cutting in the nose anymore. I'm using a scope to guide to make sure that I don't puncture.
That you don't puncture into the nose?
Yes.
But you're cutting in the mouth?
Correct.
With a piezo knife?
With a small, with a piezo or a small osteotomes or whatever. I mean, depending on the patient.
It's just a saw. A saw is a saw.
The piezoelectric, yeah, small saw, or just like the orthodontist, just look, I don't have any magical tool. Okay. So
why do you need to watch inside of the nose to get
deeper?
If
you cut through it, then you're going to have oral nasal communication. I've seen that. There's one case. So that's not what you want. You want to prevent complications, right?
So you want to go as far as you can go without going too far and cutting the soft tissue at the bottom of the nose, which causes literally food to go into the nose or mucus to come down into the mouth.
And your piezoelectrode saw, it affects healing because it's heat.
It gets hot.
It's heat.
Necrosis.
Right. Okay. And if you're going to necrose bone, just imagine what your mucosa is going to be like.
Permanently damaged.
So it's a delicate operation.
So if I could just briefly, doctor, here is a sample of piezo cut having been done on a clay mold. Okay. So you see a cut down the middle here.
I don't really see it, but okay, I take your word for it. That's okay.
Okay. Here, I will do this. You see a cut down the middle here?
Well,
you see...
It's small, but let's see. Yeah,
Cut down the midline here?
Yep.
Actually, it's not a continuous cut. It's dipping in and out of the bone.
Okay.
To prevent necrosis.
Okay.
And to keep the cutting line wet to prevent necrosis, to keep the heat down. Just like a tiler, when he cuts tile, he uses a wet saw to prevent it from overheating.
Yeah.
Okay. Now, what you're saying is that what really makes ease special is that with the endoscope inside of the nose, you are able to be more aggressive than the piezo cut because you have eyes on the inside. You can get a more full release because you're not blind, which the piezo cutting orthodontist cannot get because he has to be careful not to go too deep. He has to dip in and out only. He can go, but he can't go too far because he's blind. So what the ease allows you to do is to get a more thorough release that ultimately leads to better, cleaner expansion. The appliance
That's just a part of it. That's just a
it's just a
small part
part,
of it.
but it's an important part because with ease, the appliance does no work in splitting the suture. The appliance purely expands the operation fully releases the suture.
I am not talk. I would rephrase the word of more aggressive cut. Okay. Um, I am. I am. I would say that the in my hands. Now, do you feel? Do you think that the 6 patients that I showed you, did they have aggressive operations?
No,
Were they beating
maybe
the crap out? Did I beat the crap out of them?
no.
You know.
They're 60-year-old women. I hope not.
So it's. Let me finish the operation and we could
Okay.
discuss. Okay.
Okay. Mm-hmm.
So we agree that at the end of the surgery, patients are expanded, sutures are open. Okay. Now, I am using so when you have something, so we're jumping the gun, but I think this is a crucial point. Okay. Look, every device has inherent problems. Okay. But a device that attaches the palatal bone is an inherently flawed device. Okay. It's inherently flawed to achieve nasomaxillary expansion. Number one, you've seen plenty of CT scans, and like I said, you're a connoisseur of nasomaxillary expansion. In vast majority of patients, the palatal bone starts to thin out significantly around the first molar to the PNS. Agreed?
The bone gets thinner the farther back you go.
Yes.
Yes.
And most of the time, it's quite thin. So I
Right.
don't care if you're putting 12 screws in there. The screws that are working are sort of anterior to the first molar. That's why all these custom MSC that you see are all anterior, right? They could put screws in the posterior, which I will show, but it's not doing a whole lot. Okay, that's number one. Number two, it's the operation, right? So when I'm doing the surgery, I'm making sure that there's no problems. I do it very delicately. When I do the ease, there are times I would take the TPD device in and out and see how the expansion works, and I may find out where it's sort of sticking, and I would alleviate it. You can't do that with the MSE. It's screwed on.
Right.
Right? There's so, and I could go on and on about, I'm a connoisseur of nasomaxillary expansion, by the way. Okay.
A real connoisseur.
No, it's just that I've done a lot. Not that I'm smarter. I've just, look, at the end of the day, I've done a lot and I've learned a lot, and I know what I'm trying to do, and try to think about. Look, my assistant would say, you've changed your way of doing it again. I say, yes, because I want to make it less invasive, more predictable. So, okay, so we haven't gotten to the other important aspect. So so you see how different how different it is.
Yeah, what I'm really getting from you is that ease is not a commoditizable thing that you can just put on the shelf somewhere and order from
You
Great
no.
Lakes. It's really integral to the whole ease process is your peculiar surgical skill and experience.
Look, I view surgery as an art. It's not about, oh, I'm going to do, VSP, I'm going to design this, and anybody could do that. Surgery is an art, at least in my hands, okay, in my opinion. How the bone feels, how it sounds, it's real tactile to me. Okay,
Hmm.
and look, I've been doing this for a long time, so it's and the way that I do the expansion, and by the way, if you ask any mechanical engineer, okay, doing this versus doing this is very different.
Right. The fact that the TADs of the MSEs and the custom MARPs generally
And the
are
FMEs.
and the FME are perpendicular to the bone. And so naturally there's going to be a tendency to have sort of, well, actually more like this. The
Well,
TADs are going to,
it's you can your force exertion is a lot less efficient when you're doing right angle versus just sort of pushing out. You see the guys that are you know climbing two parallel walls. These Jackie Chan or whatever. Okay,
sure,
I like to see Jackie Chan doing this with the two sticks and doing it this way. He won't be able to do it. It's the force
correct.
exertion, right? Okay, and I'm sometimes I take it in and out and reposition it and see how the device is working, and so it's look, it's an operation, it's an art, it's not selling a Big Mac. Okay,
Exactly.
all right, let's get back to the operation.
Okay. Can you talk about the role of pterygomaxillary release in your ease procedure? And are there any other places where you release in order to facilitate the expansion? And maybe I'm wrong. Do you even do pterygomaxillary release? Because certainly the rumor is that you do, but I don't know. You can tell
Yeah, I
me
do. I do a piezo delicately, and
here. This is this is the
yeah,
pterygomaxillary area.
yeah, that's where they get swelling in the cheeks because of the pterygoid separation, and they get some nasal swelling from the manipulation of the scope and in the anterior maxilla. That's where they get the
Are,
swelling.
are there any other areas that are released besides mid palatal and pterygo?
That's it.
That's it. Yeah.
Look, it's how the surgery is done delicately, and it's how the expansion is done during surgery and post op for months.